So my name is Nisha Mackenzie. I am a physician assistant in Grand Rapids, Michigan. I founded a medical practice called the Center for Women's Sexual Health a few years back. And I'm here with...
I am Audrey Mitchell. I am a therapist and social worker, and I co-own Grand Rapids Specialty Therapy, and we have a unique collaboration that we work directly with Nisha within the same space.
I kind of feel like we should just all sit at one table and just do a little intimate talk, but I think we'll throw off the camera guys here. So we'll just chat and we'll let people come in if they need to. But we are also really open to, if you guys just have questions, shoot your hand up, and we are not at all needing to show you a presentation. So if you just want to talk and collaborate this way, whatever works for you guys. So we'll start off this way just because sometimes that starts to elicit some questions, but I think they put index cards on your tables as well. So if you have questions, then I will come around, or Audrey will come around, and we'll grab them and we'll read them off to people so you don't necessarily have to speak up. Yes, so you guys will not be on camera. It will just be us, which we were just informed of too. So I recently, actually just last week, was in a conference, and a colleague of mine and a friend of mine had just done a study with patients living with metastatic breast cancer. And she had surveyed over 70 patients as well as healthcare providers. And these are some of the things that she had seen that healthcare providers had said during her survey. This was just this past year. Vaginal atrophy, which is dryness due to either menopause, chemically induced, surgically induced, removing your ovaries, chemotherapy, anything like that. So vaginal atrophy has never been an issue with my patients. Never any complaints. Vaginal discomfort is a concern, but not a horrible side effect. Metastatic disease is life-threatening, so they, the women, will put up with the side effects in order to survive. It's not that much of an issue, as the threshold for patient complaints is a little higher given the nature of the disease. Minor nuisance for vaginal dryness, but I find solutions with lubricants for painful intercourse. It's a little bit of a problem. I've had a couple patients complain about that, so I switch them. Otherwise, it's not a big deal. If that makes anyone else's blood boil. Beside mine and Audrey's? Boiling, yeah. These are healthcare providers today. What patients say, so this was in her same survey. When we tried to have sex, initially it was very difficult and we were actually hurting. But both of us, because it was real important to both of us, and a big stress relief. Excuse me. The doctors don't know how far you cannot go. Don't tell you how far you cannot go. They don't even discuss what you can and cannot do. What is the best lubrication to use? And maybe some different ways to work around the fact that I'm in pain. Those kind of questions would be great to have someone to talk about. I have not had a discussion about sexual health with anyone. So we do know that almost 90% of people living with metastatic disease will complain of some form of female sexual dysfunction. So a lot of my patients too will tell me, no one ever told me I would feel this way. Is this normal? I just want to be able to be touched and not feel like I'm on fire. Asian and African women tend to be less communicative with respect to sexuality, so they're more prone to female sexual dysfunction. And the most common form of female sexual dysfunction that we see is vaginal dryness that leads to painful intercourse as well as low libido. Genitourinary syndrome of menopause is something that menopausal women who are not either cancer survivors or those living with metastatic disease. So just people who go through a natural menopause, it's called genitourinary syndrome of menopause, and it affects over 40% of postmenopausal women. But even in this group, only 7% of affected women seek treatment. This number is certainly even lower after a cancer diagnosis, and only 10 to 15% of healthcare providers ask their patients in the naturally menopausal group. After a cancer diagnosis, we've got about 13% of healthcare providers that'll discuss this with their patients before treatment. After treatment, 5%. That's like none. So low. Yeah. Right.
So I just want to reiterate, if you have questions, this is a small group. we would rather answer your personal questions that you have than go through this. So if anything pops up, raise your hand and shout it out. We are very good with rolling with the flow. So we're here for you. That's why we're here.
We were kind of hoping the computer would break down.
Yeah.
Just chat.
or we'll just ask each other questions. So please use the index cards that are on your table. Otherwise, just ask away, because we will ask each other questions as well. We're very good at that. Yes.
For it here, right? So why do only 5% ask or bring it up or anything, of physicians bring it up? Why is it like that?
So that's actually this slide here. So it's a very good question, because we're on the same wavelength. We figured we better talk about that. Do you want to? Yeah.
So the barriers are the lack of knowledge and training, fear of effects, such as embarrassment, intentions of being misunderstood or seen as inappropriate or arousal. And again, these are from the healthcare providers, not the patients. Lack of known resources, lack of knowledge regarding coding, billing, reimbursement, time constraints. This tends to be a big one. Belief that patient appears happy or healthy, so there's no need to ask. Underestimation of prevalence, and minimal FDA-approved treatments for female sexual dysfunctions. Does that answer your question, or would you like us to explain more?
There was one point that I said, it was earlier in my diagnosis, I just said to my oncologist, do your other patients, are they having sex? And her comment was, oh yes. And that's all that she said. And that was the end of that.
That's not very validating, is it? So that's, I'm going to guess, I have no idea who your provider is, that she's a fabulous provider, probably brilliant at what he or she does. You said she, right? Oncologist. So really well trained there, but sex is taboo, right? We are trained from the get-go not to talk about sex or sexuality. And that doesn't change just because we go to medical school or PA school or even to become a therapist. Audrey and I both had to do a lot of extra training outside of, after we graduated and after we got our degrees, to learn about sexuality in a way that was more validating and a little more understanding, because no matter what, it affects every human being on the planet in some way, right? Whether you choose to or you choose not to, it still affects you. And it's not taught. So these people are taught wonderful things, but even in medical schools and even in PA schools, it's not brought up. So we're trying to change that. We're trying to both get into, we teach and we get into some of the PA schools, and I teach medical residents. And so it's starting to kind of change a little bit, but it's not changing much. The patient barriers, so you were very brave and brought it up, but a lot of patients do not. And the barriers, interestingly, are very similar from why the healthcare provider doesn't bring it up and why the patient doesn't. So fear of embarrassment, fear of judgment, there's social norms and expectations, right? So you were exposed to a social norm or there an expectation, yeah, everybody's having sex. Often I hear patients say that they've already asked another provider and they were told it was normal, which essentially is what happened to you as well, right? Oh yeah, that's normal. Everybody's having sex. There's a lack of awareness regarding coverage for services, so people don't think they can go anywhere and have their insurance cover these types of questions. Lack of awareness so I wrote HSDD, hypoactive sexual desire disorder is a treatable medical condition. It is, I would say, in either cancer survivors or those living with metastatic disease, HSDD is probably not a relevant diagnosis because you guys have a good reason, right, to have a decreased sexuality or pain. There's a lot of reasons. I shouldn't say good. There's a lot of reasons. There's just solid reasons. So HSDD is one that we diagnose when there's no reason, right? And then the fear that the provider might try to fix your sexual interest or behavior. So what if your sexual interest is same-sex partner, but your provider is opposite-sex partner? I'm sorry, I'm wandering. I'm not supposed to wander. It wasn't that long. It didn't take me too long to wander. And so then you might think, well, maybe they'll try to fix me, right, and change me to their line of thinking or their belief or their moral system. So there's a fear of that. So that's another reason that patients don't bring it up. There are multiple medications that people in general are on, let alone people living with disease. So antidepressants, pain medications, anti-anxiety medications, blood pressure medications, cytostatic medications. So things that are helping treat the disease at the moment, as well as treat some of the side effects or symptoms of another medication, right? So you might be on something that might be causing high blood pressure or something like that. So, and all of these medications can also decrease libido, decrease sensation, and sometimes we can't get rid of these. We have to have these.
So we wanted to touch on what does living with metastatic disease look like regarding dating or being in a partnered relationship. So re-entering the dating scene, it can be scary. When you think of how relationships ebb and flow without disease, and you throw disease on top of that, how do you disclose sensitive information concerning your health status? How do you disclose sensitive information regarding body parts, appropriate touch? How do you disclose emotional information? And when is it appropriate to do so? And I just want to be the first one to say that what you choose to disclose to whom and when is up to you. There is no right or wrong answer. It's all about your feelings and your confidence. And I cannot hit that hard enough. And processing through realistic outcomes. What if I get rejected? Worse? What if they say yes? They're both scary. So it's in STI prevention and safer sex. Nisha's going to talk more about that. But the big thing regarding dating and being in partnered relationships, and even if you're not in a partnered relationship, this whole journey, and I can't remember if it's touched on another slide or not, it's all about redefining what sexuality and, more importantly, what intimacy looks for you in this journey. Because it's going to be redefined, and it should be redefined. That we get to smash social norms about what is sex. If you go out on the street and you ask, what is sex? Most of the time the answer is going to be penis and vagina, right? Penetrative sex. That's one aspect of a total overarching umbrella. And we're going to talk about that in a little bit. But that's what I mean when we get to redefine what is sexuality to you. What is sexuality? If you're in a partnered relationship, what is sexuality to your partner? And what is sexuality for you together in your partnership? The same thing about intimacy. All that gets to be reevaluated and re-landscaped.
And there may be an actual fun aspect to that, kind of not dissimilar from when we're in our 20s, right? We have a different health status then, so obviously much different, but in that sense, but we can create what sexuality means to us then, and we have no clue what we're doing, right? Now, we've had life experiences. We're going to recreate sexuality for ourselves now, but we have a little clue. Like what's worked for us in the past, what hasn't, how to communicate with somebody, how to develop an intimacy, and that it doesn't need to be, like Audrey said, just putting a penis inside of a vagina. Like sexuality can be so much more. Do you want to touch on this real quick?
A little bit.
Got it. Okay. There was a question that came up. I didn't know if she wanted to do it here. STI prevention, safer sex. I just want to touch on that real quickly, just to note that there are certain STIs or sexually transmitted infections, HIV even, that tend to actually increase in prevalence in older ages because I believe this is probably namely because we tend to feel like, it's not the 80s anymore, right? HIV isn't a thing anymore, or I don't need to worry about it, or I'm living with metastatic disease. What do I care, right? But we also want to stress to you that we don't need to add anything on top of that, right? So safer sex is an important aspect of having some sort of relationship living with disease.
This is where I'm answering.
Okay, all right.
So communication from the aspect of partnered relationships is huge. Open and honest sexual dialogue. How often do we go through life and in our relationships and say, oh, sex is so gross. I can't talk about this. I'm so uncomfortable.
All my teenagers say that.
Just sex is viewed as a very negative aspect of life for the most part, especially when it's hard. So having open and honest sexual positive dialogue. Oftentimes, what I hear from a therapist, so in a therapeutic setting, goes right along with one of the questions that we have is, I'm going to hurt my partner. I'm going to hurt or I'm going to offend. And so therefore, I do nothing. How can we help each other? It's all through communication. So there's an intervention that we use in therapy. It's called body mapping. And what it is that you can draw, I am not an artist at all, but you can draw a stick figure or a bubble person. And it's great to do both by yourself and in a couple and highlight. So take a crayon, get out your inner child, take a crayon, bright orange, that's my favorite color, bright orange, and highlight the areas of positive touch, meaning that when this is touched, there's zero pain and there's a sensual response. And then take whatever color, gray, purple, whatever color means no in your mind, and highlight the areas that are painful or no zones, as I call them, and share them with your partner. What you're doing is you're allowing your partner into what's going on up here and not just assuming that they know areas that are off limits. And in turn, what you're doing is you're giving them permission to touch you how you want to be touched. And this all goes into the communication. Improvement in communication styles. So often we give our partners a lot of credit of being able to read our mind, when in turn, they're not. If we don't tell them, they're not going to know. If we don't know, tell them, this word makes me cringe. This touch makes me cringe. When you do this, I'm assuming that means sex. When really, this could just be a touch of, oh, I hope you're having a good day. Sorry, totally touched you without your consent. But if we don't tell and inform our partners about what we want, about our fears, about our hopes, about our positive touches, they're not going to know. Active listening, huge, right? So often when we're in a conversation, and including me right up here, and you guys aren't even asking questions, I'm already thinking about what's going to come out of my mouth next. What we can do is we can pause, especially when we're having a conversation about sexual health and how that affects our life with our partners. And these don't have to be big, like, let's sit down, we need to have a conversation type talks. This can just be, what makes you feel valued today? What makes you feel powerful? That all ties into your sexual health and wellness because it all hits the intimacy piece. So listen, be present. Use those therapeutic I feel statements. I don't know if anybody, who in here knows what I feel? Who in here uses I feel statements? Okay, so what we're I'm mindful of time, so we're not gonna spend a whole lot of time on this. So when you feel something, it's oftentimes, and this is more used in argumentative stances, you never are on time, which is accusatory towards our partner. That's the way we intend it. A way to say it or reframe it is, I feel put in your emotion. I feel left out. I feel sad. I feel abandoned. What that does is it allows us to put our emotions first and not accuse the other person or assume the other person knows how we feel. This is a stance of active listening. So especially as a partner, if any of you are in partnered relationships, I don't know if you've heard from your partners of, I don't know what to do. I feel lost. You always turn me down. Being able to reframe that and putting it in a way of, I feel da-da-da-da, is just a way to be an active listener. Sorry, that was totally a tangent. Please interject if you have anything. And non-judgmental attitudes. Partners don't want a traffic cop, but they do want instructions, even if we don't ask. So this little cartoon up here, they're not up there anymore.
I wanted to do a little edit. I'm just not very good at computers, and say just they're not, cross out up, right? Maybe they're not even there anymore, right? And that would be a good time for an I feel statement. Maybe, instead of you never touch my breasts anymore, I feel that you're scared of them. I feel unloved because you don't touch me there anymore, or where my breast tissue was, or, that type of thing. Sorry.
No, you're
I
fine.
just wasn't creative enough to edit it.
But so the non-judgmental attitudes, so much of sexual health, we get all these preconceived notions, and I'm so sorry, I'm like totally bashing society today, of what society tells us sexual health needs to look like. And most of it is wrong. So those non-judgmental attitudes are being able to take a step back for yourself first and reframing what does my sexuality look like, and give yourself a whole lot of grace and love. And also your partner a whole lot of grace and love. As you are fighting and relearning what sexual health and what life looks like, so is your partner. Invite them in on your journey with honest and direct communication. Also knowing that you don't have to own their emotional dissonance. They get to own their emotions and you get to own yours. Questions? I see a couple confused looks. We love questions. Yeah.
You know, I guess it is a question down the road, but I'm listening to you and looking at the information, and a lot of it I agree with. But I'm just wondering, first of all, we live in a very double standard world for women.
Yes.
The expectation is unreal when it comes to women. And then as we age, okay, that's another barrier. And needless to say, if you're dealing with the cancer too. So, but then the other aspect for me, what about the cultural differences? Because the expectation, depending on the culture, is different. So having a conversation about sex can be kind of,
Absolutely.
okay? So how do you approach that? Because, I mean, how do you tell this particular person this in this particular culture when you're expected to be this kind of a way? Because women are always put in a box, to me, to be a certain package, you know. So, I mean, because of the cultural differences, how do you approach it?
So that's a really great question. Unfortunately, they only gave us an hour, so we couldn't put a whole lot of culture in here because that would be, I mean, that's such a huge topic. I'll probably let you take that one.
Okay.
If you don't mind.
So my approach with that is maybe a little bit of a different answer than what you're going to be looking for. But for me, it's a workaround. What I have found with my clients, specifically for the topics on cultural and putting people in boxes in general, what I have found when you go after that box head on for individuals, it tends to explode. It's the same way I talk about fear. Fear is smart, boxes are cement. So when you go in, like, let's talk about, I can't think of a good example. Let's talk about something that, you know, in your specific culture, sex is not talked about. It's highly taboo, right? So by saying, I want to be a strong sexual woman, whatever that looks like, I want to be a strong woman, I'm also a fighter, like going at that head on, it tends to explode for people and cause a lot of increased anxiety and increased depression for the weight of, I can't change this, is often the stories that we tell ourselves. The workaround is looking at the ways, still tying it into sexual health, because sexual health is a spider web. It's not just a one-liner. It's this intricate web. So looking at it of ways, how do you feel loved? How do you define your value? How do you define your power, your acceptance? And looking at it as a different lens around it to kind of work around it from the back. So I know it's not like a direct answer to your question. I wish I had a better one. But for me, in a therapeutic setting, it's the workaround. It's tying in this next slide. A lot of CBT or cognitive behavioral therapy interventions to get our minds to reframe and work within those cultural contexts, because those societal norms and cultural contexts, they're huge and they're important. You don't want to take them away. They're what make us individuals, and they're what make us different, and they're what makes us strong. So also tying those in as you're doing the workaround. Does that make sense?
Well, yeah. I mean, you have to start somewhere, and I agree.
Okay.
But in addition to the cultural thing, I was thinking about the whole programming, because sex sells. I mean, on the TV videos. I mean, so to go to your partner and say, well, listen, my vagina is dry. I mean, not just like
Yeah. You can say it just like that. That's perfect, actually. This hurts because.
You know, depending on who it is you're dealing with, really? Okay, get on that, you know? Yeah. So, I mean, it's a very complex situation.
It is so complex.
So I think you just have to be confident and find your confidence somewhere, and then hopefully you can connect with someone who got some sense, you know?
Yes.
Yeah. I think finding,
Like you said, finding your confidence, but then also finding a good, objective mediator almost, or a therapist who can help you do that, because these things are so nuanced, right? So culture and religion, and someone who's trained like Audrey's trained can go in no matter what the culture, no matter what the religion. They don't have to have that their own a similar belief system to help you do what she said, and find the workaround and say what is important to you. And then she can help you find those words sometimes. So I think that's it. You're next again.
Also, you have lubrication samples on your tables for the vaginal dryness.
So good clean
They're-
love, Uber Lube.
They sprinkle chocolate, we sprinkle lube samples.
yes.
I have more of a comment than a question. When I was, this is also piggybacking on what Vic's been saying. When I was first diagnosed, which was just in December of last year, I had to sit down, my husband and I sat down with an oncology nurse and went over everything you can imagine about living with cancer, from you can't eat off salad bars anymore to these are the kind of gloves you need if you vomit after chemo to clean it up. But the sexual health wasn't touched on. So I wish that, my wish is that if you can encourage providers to have a meaningful discussion about that, so it's not, you know, me having to go to them, or I have no problem bringing it up to my physician, but I know a lot of women would.
Right.
So but if they open that discussion first, I think it would be so much more helpful to be prepared for that moment, which I wasn't, when everything in our life changed in the bedroom, you know what I mean? And then I was like, what is happening? I had a sister who had already been through menopause, and she said, oh, that sounds like what I had. And I was like, well, I'm only 45, why is this happening? You know? And it was because of the chemo, and I didn't really understand that. And I wish that they would have taken that opportunity to kind of open that discussion, or at least just open that door, so that maybe down the road, you could say, hey, you know, you mentioned this before, you know, can we talk about it some more? But I was kind of going in there cold, and I had no problem doing that, bringing it up, but I know a lot of women would.
You're right.
You know, you know, especially you're going through so much, and now you have your partner going through that part of it with you. It's really hard, and you feel burdened to be, you know,
The person to bring that up.
the person to bring that
Right.
up. Yeah.
I've actually had a number of women tell me, they saved my life, or I've gotten through this, or I'm getting at a point of maintenance or something. I don't have the right to ask for sexuality. It's not, I don't deserve that, right? And that's obviously, we all know here that's not true, but that's the feeling that comes up. So we are trying to get into oncology office. So in our area, in Grand Rapids, we work with the survivorship clinics and the oncologists alone, just to try to help them understand how to bring this up beforehand. And again, beforehand, when you're initially diagnosed, sex is like the last thing you're thinking of, and I get it. But if it's at least mentioned, or if there's a brochure somewhere, then at least you know, okay, that is maybe an avenue. I can take that street and say, that's permission for me to go and ask about that again when it does come up. So you, strong and powerful, you can bring this back to your oncologist and say, there are people out there who do this. Feel free to bring them our cards and say,
They were very willing to help and
Good.
provide information, but I had to
bring it
open
up.
that door, you know, and I think I think if you can tell me not to eat off a salad bar, and that I can't get pregnant while I'm chemo, I think you can also kind of
Could or should.
mention this.
Yes,
You know, just so
yeah.
it's a little, for me, it was okay, because I'm pretty old, but I know a lot of women.
Yeah.
You're right, and that's why this is an issue.
And it's a shameful thing too, you know, this is your relationship, you don't want things to be going worse for them, you know,
Yeah.
your care provider.
I have a friend who's an oncologist who recently told me, she said, Nisha, I was at an oncology conference out west, and there's over 1,000 oncologists here. And she said, someone brought up something about sexuality, and everybody, you could feel the whole room get tense. And nobody wanted to talk about it. And they were all like, who's talking about this? Where do we send them? We don't want to talk about it. Where do we send them? And so my next goal is to actually go to the oncology conference and speak there. Because I think I can reach broader areas there. But yeah, I appreciate that you did that. I think that's wonderful that you did, and I'm sorry that It hasn't all changed yet.
Well, even at the conference that we had for this, to talk about what we wanted to talk about today, I don't remember who it was that brought it up, but then everybody's like, oh yeah,
Yeah.
But it takes that one person.
One person.
But I think if they hadn't, maybe nobody else would have,
Probably.
But it's something women suffer in silence,
And it is a silent.
Yeah.
And then too.
And men too, yes, that's true.
And then too.
Yes, partners in general.
Let's get back to you. See if they have like a focus area, what they want to.
Yeah. Yeah, go ahead.
Do you just time escapes us like really fast? Do you guys have ladies, guys? Sorry, that's just my go-to, and it's folks. Do you folks have an area where you want us to talk about? We have like strategies for increasing low desire, flip it around, increasing desire. Nisha can talk a ton about lubrication and medication and side effects in that area. What do you want us to use the time that remaining? Because I'm bad at math, so about 25-ish minutes.
I just have a question.
Yes.
If penetration is out, if
Yes.
you and your partner decide to say, you know what, we're not going to do that, what are you offering or suggesting for those who are not going to do the penetration and all that?
Everything else. That's my very all the things. So you have on your tables, you have a sensate focus.
I don't.
Oh, you don't.
Sorry, you didn't make enough copies of that one. But if you want to email one of us, our cards are there, and we will send you an email with Sensate Focus. So those are a different one. I'll tell you about those. Sorry.
Okay.
There were
So-
two things.
Sensate Focus, write it down. You can Google it, but I will say Dr. Google is not always the most accurate route, so probably
His license is a little sketchy.
probably email one of us. But when penetrative sex is out, and when that is really the only type of sexual arousal or ways that you've been able to orgasm, if you're able to come to orgasm, if that's been the only thing that's worked in the past, it's going to be a new frontier. So an exercise that we use is called Sensate Focus. And what is it? It's touch. It's relearning touch. It starts in a non-erotic touch, or about, depending on what model you look at, anywhere from 4 to 5 different phases. And this goes to your question, but what it does is that you relearn touch in an avenue of what do I like? What pressure? What tactile sensations do I like? What areas of my body do I like? And it focuses on more of a mindfulness aspect, bringing pleasure, not how most of us view sex, not as the orgasm is how I define if it's pleasurable sex. Take that off, right? Like it's pleasure, 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 pleasure. So highlight areas of your body that have a sensual, erotic, pleasurable touch. And that's when we joked, everything is under the sexual health umbrella. So strategy. So you led me right here. Communication. Sex positive communication increases desire. Talking about with your partner, man, that green hat makes the color in your eyes pop out. It's the little things. It's the building blocks. Scheduling sex. And when I say sex, I do not mean penetrative sex. I mean any type of sensual, pleasurable touch and what that means for you. Wearing lingerie. The act of going out and shopping for lingerie together. Doing a date night. Understanding responsive desire. So without getting too technical, there's a term, it's called the dual control model, for how desire works. Most of the time, so responsive desire is the context throughout your world and throughout your day. How does that influence the ways that you feel sexy or want to engage in any type of sex? Becoming aware of where are your brakes and where are your accelerators, what revs you up, what slows you down, and becoming mindful of how do you incorporate what revs you up into your daily life. Toys, vibrators. That's a huge aspect, and most of the time taboo. People kind of, what? It's an area of exploration. Foreplay, cuddling, the novelty, bibliotherapy, the talking, making alone time together, and making alone time for you as well.
What is bibliotherapy?
Thank you.
Reading
Reading.
Oh,
Erotic material.
Oh, I gotcha.
So sometimes erotic material, and then even sometimes one of our favorite books is, if you would like to, this is not a book about cancer or anything, just about female sexuality, is called Come As You Are. It's by Emily Nagoski. It's available on Audible, so you can listen to her, and she's a real dynamic speaker, and she actually narrates it. Sometimes those Audible narrators are really bland, right? But she's very good. And it really is a great book that brings all the research that there is on female desire into one nice, easy-to-read book. She's got a lot of great metaphors in there. It just helps you understand that essentially, because we're social bashing, right, society bashing today, but essentially we're trained that the male version of sexuality is the gold standard. So all of our lives, from the get-go, we're like going, oh, we're off balance because we're trying to achieve that level of sexuality. Now, in dudes' defense, they're also off balance, right, their whole lives. They're going like, wait, how come you're not here, right, with me? Because they don't know also that they're maybe not the gold standard, that maybe there is a there is a difference between female sexuality and male sexuality, and that's okay. How do we meet in the middle? So this book really outlines that really well. So bibliotherapy is that. Sometimes we'll give them the whole book. Sometimes we'll give them chapters. Sometimes it's erotic material. Go ahead. Emily Nagoski, Nagoski. Right? Nagoski. That sounds right. Yeah. And then I would say also, to touch real quickly on that responsive desire thing, we do know that women tend not to have spontaneous desire. Now, sometimes in the 20s-ish, like, right, real early, that might happen a little bit, but there's also different things that drive us, and less stress sometimes that's like clouding our brains, right? Women tend to have arousal first, and then that precedes desire. So once there's actually a genital arousal, a touch arousal, a connection, emotional connection, something that turns that on, then they start to experience desire. But they don't really just walk down the street, and just like, oh, it's sexy time, right? Oftentimes, women have to have something a little bit more tangible. So I just wanted to touch on these real quickly. If penetrative sex is an option for you, but deeper penetration is painful, there are a lot of different things out there that can help. And two of them, one is called the O-nut. That's the upper right-hand corner, and then that middle one. And it's just these little silicone bands that basically act as spacers. So if it's a male-female partnership and they're trying to experience penetration, put this at the base of the penis, and you can see in that upper right-hand corner there, you can unstack or stack up to 4 of them, or you can buy more. So that you have more space. So you can continue to thrust if you'd like to thrust, and then the penetration is limited. So if deeper penetration is painful, this is a nice soft one. The one that we used to have down in the bottom right is called the Come Close ring, and that's available through the UK. It's a little bit more firm and a little harder. It works well, but I think most of my patients tend to like the O-nut a little bit better. These are dilators. So again, I don't mean to focus on penetration, but if penetration is possible but painful, some of these things can help. So dilators are kind of like those little Russian doll sets that sit inside each other, so they gradually increase in size. They're not necessarily trained to or make the hole bigger, but they're to train the vagina, to train the brain that something can be in there without pain. So we do it slowly. You do it on your own. You use lubrication. You put it in, and nobody likes to lay in their bed frog-legged, right? So you kind of lay off on your side or something. Watch a show. Listen to Emily Nagoski's book. Meditate. Talk to your partner. Sleep. Give it 10 or 15 minutes, and then you can gradually increase in size. And that's training so that if you can't, general erect penis size might be in the upper right-hand corner like a D or an E. If you can't just start with that, then you also probably can't just start with sex without pain. And if you try to have penetrative sex, then what happens is our brain starts to associate that partner and his penis with pain. And those are hard neural pathways to break. So we start low and slow, and you do it yourself because you can control that much faster than you can to have your brain tell your partner that there's pain and then have your partner pull that away, right? So you do it yourself, and these can be very effective. Sometimes I like to call them trainers instead of dilators. some of the non-pharmacologic things that we do for pain and dryness. So you have the lubricants there. Lubricants are to be used for outer course and inner course. Oh, I do want to say real quick, you were talking about penetrative sex and how that's not necessarily, I think you had asked it, what if we can't do that anymore? I just want to throw one staggering statistic out there. Only 3 to 10% of women will reliably orgasm. This is not in a cancer population. Will reliably orgasm with a penis inside of them. Only 3 to 10%. So where do women experience pleasure? Generally, external, right? Foreplay, which is also one of my least favorite words because it makes it sound optional. It's not optional. Right? If female pleasure is to be held at the same standard as male pleasure, then this is not optional. So then, yes, maybe penetration is what the male partner needs. Outer course is what the female partner probably needs. So lubrication, anyways, is to be used always. Outer course, inner course, because, we're just not walking around in a pool of wetness, right? All the time. There's always some dryness, even when there's not a menopausal or a post-cancer state. Right? There's some dryness. And so then there's little tears, there's little micro tears. You might have an increased risk of infection. So we need to use some lubrication. Moisturization, this is really important for anyone who's had a natural menopause, a surgical menopause, a chemotherapy-induced menopause, anything like that, that you're going to use this like you use lotion. So if you put lotion on dry elbows once, your elbows are still going to be dry, right? You have to do it all the time. So moisturizers are not used right before a sexual encounter. They're used almost every day. And then the lubricants are used right before a sexual encounter. And then massage. You know how if you get a kink in your neck and you go like this and you massage it out, right? Why do we do that? Because it brings blood flow to that area. It helps the tissues gain some elasticity, and it helps the tissue and the muscle heal. So vaginal, vulvar tissue and muscle is no different. It's taboo because it's a vagina. Can we all say it? Vagina. Even the gentlemen in the room, vagina. So my 8-year-old, well, she's not 8 anymore, but when she was 8, she was like, Mom, I know you said I can't go, because they always see me, make these lectures and everything, and they'll come up and they'll go, what's that? And so they might be a little bit better informed than they should be. But she goes, Mom, why can't I say vagina at school? Because I tell her, you guys don't talk about what we talk about here at school. You're going to offend somebody. And she goes, it's just a body part. If I can say elbow, why can't I say vagina? I go, right. Yes, I don't have an answer, but you're right. So anyways, we massage it. So we actually, the papers that are on your tables talk about how to massage that area, because when that lacks blood flow, it will be painful. Kind of like if your arm falls asleep, right? And it's tingly and it's painful. So when you lack blood flow to the vulva, to the vestibule, which is the opening, or to the vagina, it's going to be painful. So this is why people will say, if you don't use it, you lose it. And I go, oh, that's the worst, because it's true, but also because people then they think that means if I don't put a penis in it, I'll lose it, right? No, you can massage it yourself to bring blood flow to the area. So that little handout talks about how to massage. And then we also use something in our center called vibe therapy. And I call it that because there are a lot of partners, a lot of people who are intimidated by using a vibrator. So you don't have to use a vibrator for pleasure, but you use that vibrating massage wand on your neck, right? There's muscles there, there's muscles here. And the pelvic floor, we don't talk much about this today, but the pelvic floor physical therapy is vital for almost all of our patients, anyone with pain, because those muscles are guardians. And when there's pain at the tissue, the muscles are gonna go, zzz, nothing's coming in here. I'm going to protect. And then they stay in that protective spasm for years. It's like a perma-Kegel. They just stay there. I'm sorry, did you want to say something? No, just agreeing? Okay. So vibration. Yes, that pelvic floor is so vital. My pelvic floor PT at our practice taught me that even when people have jaw pain, she said, you probably have a tight pelvic floor. What? Like, that's not in the song, like the jawbone's connected to the pelvic floor. It's not at all it. So, but everything is connected down here. So hip pain, back pain, anything in the lower extremities, all of that can be from your pelvic floor. So then we have a couple of different devices that will go in and curve a little bit and then vibrate. And they can go in and almost do like a trigger point release on that muscle in the pelvic floor. That is somewhat similar to you doing pelvic floor PT at home, because if you go once a week, your muscles have 6 other days to regain that muscle memory and go back to that spasm. So vibe therapy is really important to use. We can use laser energy methods, and we have this in our practice for our patients who have been diagnosed with cancer, because most often, they either aren't comfortable or can't use any kind of estrogen, right? So and estrogen supplies that elasticity and that robust tissue to the vaginal tissue. So if we can decrease the amount of pain you have with estrogen, hallelujah, but if we can't, what else do we use? The massage, the vibe therapy, the lubricants and the moisturizers, all really important, but sometimes the laser does essentially what the estrogen does without the estrogen. So there are some good lasers and some not so good lasers, and if you have questions, you can call me about it.
Questions. I keep asking because I know you have them.
You know what? What about the individuals who have sensitive skin and, some ways you're allergic to the rubbers?
Yep.
But what about some of those lubricants, the liquids? I mean, are there anything that can irritate them?
Yeah. So I usually tell people, the ones that we have on your table here, this one is Good Clean Love and the other one's Uberlube. Those are really clean products, so I don't tend to see people have reactions to those. You do want to watch what's in your lubricant. And there is I'm going to Google this and put it in your Google search because I might have a couple of the words wrong, but I think it's called a Woman's Touch Resource Center. Is that Ellen Barnhart's center, a Woman's Touch? It's in Wisconsin, I believe. And she has a whole chart on lubricants and what's in them, what their pH is, what all the ingredients are. But some of them, what I also tell people, you know how if people have allergy testing, they do the forearm right here? Take a lubricant and put it there on your forearm and see if you have a reaction. That's a much better test than putting it on already mad tissue and then going, ugh, I need a tub to sit in or something. So try it on your forearm and see if that's anything that you react to, and then you can move to something different. But usually some of these, like this Uberlube, is a really clean product. People don't tend to have issues with that. Some people will use coconut oil. As long as you're not prone to infections, that's fine. And it's very helpful for moisturization, and it can be very soothing. So some people I'll have patients put it on just right after they get out of the shower in the morning, and it can be very soothing. But, certainly some people might have an allergy or something, so you do have to watch that. I think we'll, yeah, go ahead.
Why did you say in case you're prone to infections?
So some people will, after the estrogen leaves our vaginas, for whatever reason it leaves, the pH goes up and we have a higher risk of bacterial infections. So if you have a higher risk of bacterial infections and you're putting coconut oil in there, you might be trapping something. You could trap bacteria. The coconut oil I don't find so much, but some of the oils can get rancid, right? Like olive oil. So you just want to be careful with what you're putting in there. I have patients we could have a whole story session about what I've found in vaginas and what patients put in there and what they use to clean them, and Pine Sol and toilet bowl brushes. Like, right? Everybody went like this. So I just tell people just to be careful. Just if someone does have a recurrent infection, it would be my job to say, what are you using there? And if you're using coconut oil, I'd probably tell you to stop. Not that it's causing it, but it might be perpetuating it. I think, this is our last one. You want me to do it? Sure. Okay, so everything is a balance, right? Everything in life is a balance. I achieve no balance anywhere in my life, but I always say, people always ask me, how do you achieve balance with, doing this medical center, having your kids, like all this stuff, and I say, I don't. There's some days that I spend 28 hours in one day, either with my kids or the 28 hours in one day with my practice, right? So there's no balance there. The balance, I think, lies within. And if I, at the end of whatever day I have, can say that my my goals and my mission and everything I did in that day aligns with my belief system and what I want to do to further this world, further myself, then I've achieved balance. But the balance with sexuality after cancer is probably even more fraught with problems, right? Is because it's so on the ends of the scales, right? It's so intense. It's not just a day-to-day thing. So this is such a skeleton version of the negative aspects of what people go through after a diagnosis of cancer, but pain and fatigue and less lubrication, decreased sensation, anxiety and grief. And we really didn't get a chance to touch much on the grief part of a diagnosis today, but that's a huge aspect of this. So we try to capitalize on what positive things there are. So if you were to go into a therapist to say, listen, I just want to be able to keep my head up and walk through the day. We talk about the differences in communication. You're going to learn a different communication style because you have to. Where people who haven't been through something such as what you've been through kind of take some of that for granted, right? And they maybe become complacent in their communication because everything's going to be fine. So you're going to learn a different communication style. You're going to increase your mutual understanding of each other because you're going to be communicating in a different way. And even if you're not partnered, you're going to be communicating with yourself in a different way. We also didn't really get a chance to touch much on body image, but obviously that's a big part of having surgeries and what that society thing does to help us define ourselves as women. And these are the parts that are affected, right? That may be taken away from us when we're not ready for that. And so we're going to come to a different mutual understanding even within ourselves of how to talk to ourselves in a positive way. More thoughtful, careful sexual contact. This, I think, brings in what that last bullet point with mindfulness and what Audrey was talking about a minute ago with sensate focus, to say that if we can be present with our partners or with ourselves in a moment, any part of our body can be sexual, right? We have sex with way more than just our genitals. We have sex with our brains, our skin. People can learn to have nipple orgasms, tantric orgasms, right? So there's different ways to be in touch with our erotic selves, and that can be, and oftentimes that takes slowing down and becoming more mindful of what we are doing with our sexual contact. And then there can be a greater intensity in our emotional intimacy, right? There's a greater need to connect, a greater want to connect, less complacency. Right? We really see the world in a different way. And those are some of the positive aspects. And so in a therapeutic alliance, if you have a therapist, they may often go back to that and say, here's where your successes are. Let's kind of build on that and help you understand how to make that maybe a bigger portion of your day. I'm not going to speak to what you do. I'm sorry.
No, that's right on. Keep going. You're doing good.
Here I am. This is what Audrey would do.
You're right on.
When I channel my inner Audrey when I'm in a room with a patient, that's what I would say. So those are some of the things. And then just the last slide we wanted to tell you, and one of the things that we both find really important to know is that our longest and our most trustworthy sexual relationship that we have in our lives is with ourselves. Right? We have partners. Some of us have wonderful partners, right? Some of us don't. Some of us don't have partners. But regardless of any of that, the longest and the most trustworthy is with ourselves. So learning to be sexual with a partner will only happen in a positive and healthy way, and sustainable, I should say, will only happen once we've actually tapped into our own erotic, authentic selves. Because otherwise we're just having duty sex, right? Nobody wants to have duty sex. Nobody should have duty sex. So that was kind of our last thing we wanted to say about that. Do you have anything else you want to add?
Questions?
I guess Audrey's going to answer questions.
Well, you guys didn't get into dating very much. I think there was one slide.
Yes. Yeah.
But, you've got people who are single either through divorce. In my case, I'm widowed. Nothing like becoming a widow and then getting metastatic breast cancer, because, that's a pretty quick way to make someone run out of the room who you don't know very well. So I don't really think there is a solution for that situation. But if you guys have any insights on that, it would be great, into how to, you meet somebody, you kind of like them, but you have this disease. When do you tell them? Do you tell them it's stage 4? you know, all of that. And that, I have gotten into situations where I've gone out with someone a few times and then they can tell because I have some mobility issues. And I'll just say, you know, I have some mobility issues and I don't really get into it. But that's usually when I stop going out with them because I know that it's just going to be, especially a lot of people who are widowed in their 50s, they're, the guys you're dealing with are also widowed, often widowed, and their wives died of cancer. So, you know, they hear cancer and they're out the door. So,
That's an interesting point. We were talking about this in the car on the way over.
wisdom for that, but
I wish I had a textbook answer, and of course I don't, because life you don't. So I'm going to softly challenge you, and then I'm going to answer your question. So my soft challenge is, how do you know for certain they're going to run? I don't want an answer. That's just my soft challenge. My kind of answer to your question, and what makes it very individual, is it's up to you with what you want to share. So by not sharing the whole truth is not lying. So you get to define what's a meaningful relationship for you. Is it companionship? Is it a sexual relationship? Is it a best friend? What is that? What are you looking for? And then you get to share your story and who you are when it's comfortable for you. So, and specifically for the dating world, you know, you're dating. Most people are looking for some sort of physical interaction. There can be lots of different reasons as why your boundaries are here regarding physical. I can kiss. Everything out of there, I don't do. You know, you can have your own boundaries for that. So I think of this not necessarily through a disease lens, but through a boundary lens. And I know that they're both, and they're very similar. But you get to put your boundaries where they fit for you, and you don't owe an explanation to anybody until you want to share that, if you want to share that. So I just want to empower you to spend some time for you to think about where those boundaries are. And you don't know for certain what somebody else is going to do with the information that you give them. We have our assumptions, but we never know for certain. Sorry about.
They have similar boundaries.
Sorry to softly challenge you.
Any other questions?
I don't have a question. I just want to comment. I appreciate you ladies today because I've learned something. But, you know, from what I've gathered and what you've talked about, Marty, is real, and what you've said.
Yeah.
And I know we have to be positive, but I think we have to know who we are, accept who we are, and acknowledge whatever it is we're going through. And it's just an acceptance of ourselves, being happy with ourselves in spite of whatever else is going on. And I think that spirit will come out.
Yeah.
So I think at the end of the day, it's about ourselves.
I like the way you said
That's what
that.
I get from you. I hope that's.
Yeah. Yes. Absolutely.
Yes. And give yourself grace, because it's not something that comes easy. It is learned and it is worked upon. It's very easy for us to stand up here and be like, oh, great boundaries and do this and feel so highly about yourself. It is a constant everyday battle, right? Like it's give yourself the humility to stumble and the encouragement to come back and hit it again.
Put our hands together. Thank you so much. Thank you, Nisha and Audrey, and that was spectacular. I could have handled more from you. So you're on the roster for the next conference, okay?